Hello and welcome to this talk on cardiology as part of the school's open day. My name is Rohan Wijesurendra and I'm a clinical lecturer in cardiovascular medicine, and I also teach the clinical students here at St John's College. I'd like to speak to you a little bit about some of what we do in cardiology, to show you a bit about the physiology, the normal working of the heart, pathology in terms of what goes wrong, and clinical practice in terms of what we can do to fix things. So cardiology is the study of the heart and the circulatory system. You can see here a nice example of a replica of a heart. What may not be completely obvious, however, is that this is actually made of chocolate and is available to purchase online. It's amazing what you can find on the internet, and even more amazing that some people would choose to give this as a Valentine's Day gift. So why a talk on cardiology? Well, I think it's a good exemplar for many medical fields. There are many examples of how scientific understanding directly leads to changes in clinical treatment. I can show you some examples of cardiac imaging, which is intuitive and easy to interpret, and show you some examples of the rich evidence base that we have to base many of the treatments that we use on a day-to-day basis. I'll also end the talk by showing two examples of modern cardiac treatments which are linked directly to the underlying pathophysiology, one focused on the plumbing of the heart and one focused more on the electrics. When we think about the heart, we can think about the physiology or normal function. The heart is a pump. It has two parallel circuits. The left side of the heart, so the left atrium and the left ventricle, act to receive oxygenated blood coming back from the lungs and pump it to the systemic circulation or the body. The right atrium and right ventricle receive deoxygenated blood coming back from the body and pump it to the lungs. This is an image of a human heart generated using magnetic resonance imaging, or MRI. You can see the heart labelled here, the left ventricle, the thicker muscle needed to pump blood around the body, the right ventricle, and the two atria. And separating the atrium and the ventricle on each side is a valve. We can see the heart pumping in action, and we can image it carefully, seeing the valves open and close and the muscle contract. And this is normal cardiac function. We can also take a different axis of imaging. So if we imagine cutting through the heart at this level, we can see the heart in short axis. Again, the left ventricle and right ventricle are labelled, and we can see the pumping action of the heart in this normal patient. When considering the function of the heart, the blood supply is critically important. Why is this? Well, the heart is a very metabolically active organ. If you try clenching and unclenching your fist 60 times a second for a minute, you'll soon find that you get tired. But the heart continues to pump at this sort of rate throughout life. In order to do this, it needs a continuous and uninterrupted supply of oxygenated blood and other nutrients. This is delivered via the coronary arteries, which are the first branches of the aorta. In normal anatomy, there's a left main coronary artery that divides into the main anterior descending branch down the front of the heart and the circumflex branch that wraps around the side of the heart. The right coronary artery comes off separately and supplies the underneath of the heart in most people, as well as the sinoatrial and atrioventricular nodes. Atherosclerosis is a common condition that can potentially affect any artery in the body, including the coronary arteries that supply the heart. This is responsible for many of the clinical problems that we see in cardiology. This condition can affect anyone, but particular risk factors are described, including increasing age, being male, having other medical problems such as diabetes, high cholesterol, or high blood pressure, having a family history of atherosclerosis, or being a smoker. This diagram illustrates the progression in atherosclerosis over time. At the beginning, the artery can look relatively normal, but there's inflammation within the vessel wall leading to infiltration with blood cells that then take up cholesterol and other fat-like deposits from the bloodstream. This causes accumulation and deposition of this lipid core that builds up over time, eventually to the stage where it can start to affect the blood flow through the vessel. The cap of the lesion is made of fibrin, and this can rupture, leading to the internal material being extruded into the vessel and leading to a blood clot, which can cause a heart attack. This slide shows how atherosclerosis in the coronary arteries can lead to clinical problems in more detail. At the beginning, the artery is relatively normal. It has a healthy lining and the lumen is completely unobstructed, meaning that blood flow can continue unimpeded. As atherosclerosis develops, a plaque forms that gradually begins to impinge on the lumen. When it gets to a certain size, normally around 70% of the luminal diameter being affected, this can cause what we call stable angina. In this situation, blood flow at rest is normal, and so patients will feel well. But when exercising and needing increased blood supply to the heart, the vessel is unable to carry the amount of blood required, and patients will often complain of typical chest pain when exercising. This gets better if they rest or take medication designed to open up the blood vessel. And treatment for this can consist of either medications or trying to open up the artery using a balloon and stent. The other way in which atherosclerosis can affect the heart is if the plaque becomes unstable. This refers to the fibrous cap becoming disrupted and the lipid-rich material coming out into the bloodstream and causing a blood clot or thrombus to form. If this thrombus either partially or completely occludes the blood supply, then this will cause an acute coronary syndrome or heart attack. If we think back to the blood supply of the heart, we can see that if atherosclerosis can affect any of these vessels at any point. If there's occlusion to the blood supply here, we can see that all of the area of the heart supplied by that blood vessel will start to die. If that blood vessel is not reopened very quickly, that heart muscle will be irreversibly damaged. And this is what happens in some forms of heart attack. This is what a patient having a heart attack may look like. They may look pale, grey, sweaty and clammy, complaining of severe chest tightness and feeling breathless and sweaty. But not all patients have these typical symptoms. Sometimes the pain can be very subtle or can be mistaken for indigestion or muscular pain. It's very important, therefore, that we educate the public to recognise that chest pain is a potentially serious symptom that needs to prompt urgent medical attention. So we've recognised the symptoms of a heart attack and we know what the underlying pathology is. There's a blood clot in a heart artery and this is impeding blood supply to the heart. So how can we treat this? Well, historically and logically, there are two main approaches that we could take. One would be to give an injection of a clot-busting medication into a vein. This has advantages. It's quick and easy to apply, but there are also disadvantages. It travels all around the body and so doesn't affect only the heart artery, but also elsewhere, potentially leading to complications of bleeding. The alternative is to deliver a specialized wire and balloon to the affected artery, and by opening up the balloon, disrupt the atherosclerotic plaque and open up blood flow. We can then put a metal scaffold or stent in that sits in the artery and holds it open over time. Which of these is the better treatment? In order to answer this and other questions in cardiology and in medicine, we can use a randomized controlled trial. This is where we take a population of patients, for example, in this case, patients having a heart attack, and randomize them. This can be thought of as rolling a dice, so that they're by chance allocated to one of two groups. One group would have the control treatment, in this case, the clot-busting medication that's been around for decades. The other group would get the new treatment, in this case, the balloon and stent treatment that we call angioplasty. And we can compare the outcomes. How many patients die, how many have recurrent heart attacks, how many have bleeding complications, for example, to see which is the better treatment. This exact experiment was done in many trials over the years, and they've consistently shown that angioplasty is the better treatment. More patients survive, fewer patients have recurrent heart attacks with angioplasty than with the clot-busting medication streptokinase. And this can be shown to be the case over many years of follow-up, saving many thousands, potentially saving many thousands and millions of lives. But of course, in treating a heart attack, timing is critical. We've already considered that there's a blockage in the artery and all of the heart muscle supplied by the artery is dying. Every minute that goes by, that muscle damage becomes worse and eventually becomes irreversible. We can therefore see that the quicker we can open that artery, the better patients do. The fewer patients will die or have recurrent heart attacks with early intervention than with later intervention, and a matter of an hour can be critical. So, timing is critical. How can we deliver a complex intervention like coronary angioplasty in a time-efficient way? Well, this starts with recognition of the problem, patient having a heart attack and someone calling 999. An emergency ambulance will recognize that chest pain and a potential heart attack is an emergency, and a blue light ambulance will be sent to them. Fortunately, the ECG, which can be recorded in the ambulance at the bedside, is very diagnostic of a sort of heart attack that needs emergency treatment. This is an example of an ECG, and there are features here called ST elevation that tell us that the artery at the front of the heart is likely to be blocked. This patient needs emergency treatment. They'll therefore be taken to a centre that can do primary PCI, such as the John Radcliffe Hospital Not Here in Oxford. And the patient we've brought to a cardiac catheterization laboratory like this for this treatment. So how do we do coronary angioplasty? Well, we need to get a wire and balloon to the affected artery around the heart. This could potentially be achieved from any artery in the body, and historically was done from the femoral artery that provided rapid access up to the heart. The problem is that the femoral artery is large and difficult to compress, and so there are a lot of bleeding complications. So a more modern approach is to go from the radial artery that's much easier to compress after the procedure. Whichever artery is used for access, a small sheath or tube is inserted into that vessel, and this is used to allow a catheter to enter the arterial circulation and get up to the coronary arteries. The catheters are shaped such that they will easily access each of the left and right coronary arteries. The next slide contains a video that shows this process being done in real time.
The ambulance entrance and the paramedics who had diagnosed the heart attack brought the patient directly to the cath lab, having pre-alerted us prior to that. So we were all ready to receive the patient. His ECG clearly demonstrated that his inferior wall, the undersurface of the heart, was in trouble, with most likely culprit being the right coronary artery being occluded. He was having an inferior ST elevation myocardial infarction.
So the sheath, please, Jim. Go with the JL35, look at the left first, and then we'll go with the bobber guide. Bit of pressure in the wrist. Now you're going to feel a hot flush in the arm. That will wear off in a few seconds.
The first priority is to gain arterial access. In this unit, the vast majority of us go through the wrist to the radial artery, and from there we pass tubes all the way up the arm, up to the aorta and into the coronary arteries to take pictures of the arteries and confirm which artery it is that is occluded.
Okay, just sitting here. Ready? And there is where the problem is. As you can see in the middle, the right coronary artery is subtotally occluded with very poor flow in the distal vessel. So let's have a pilot 50 wire, please.
And the priority is to get that artery open as soon as possible and minimize the duration of ischemia, the period where the heart is starved of oxygen and blood.
Good. Go up there. 6, 8, 10, 12. Down you come. That's the 12. Balloon going up within the artery to release the blockage and restore flow to the distal vessel.
And once we've done that by sucking out the thrombus with a thrombectomy catheter and ballooned to restore blood flow to the distal artery, then we scaffold the artery with a stent to maintain the artery open and prevent it from reclosing in the days and weeks ahead.
Now we're going to put a metal stent in the artery to keep it open and allow blood flow to the distal artery. Test that, please. Just twist in. 38. So 3538.
3538.
Well, I think the procedure today was really a tribute to the whole team. From the moment the diagnosis was made at the patient's home by the paramedics, they very speedily brought the patient to us. The whole team here was ready and prepared, and everything went extremely smoothly. Very successful case. The patient had minimal duration of ischemia. The door to balloon time, I think, was somewhere in the region of 20 minutes. And it really is a tribute to the team. The team did fantastically well, and the patient should do very well indeed.
That looks good. Key cranium. And then RAF. So the artery is nice and open. Your pain should all settle down now.
So as we've seen, angioplasty can be an excellent treatment that can potentially save a life in the context of a patient having an acute heart attack. But what about preventing further heart attacks? Well, medications are very important. Patients will be prescribed aspirin and often another antiplatelet drug for at least a year to reduce the risk of recurrent clot formation around the stent and in the other coronary blood vessels. Statins are used to reduce cholesterol and reduce the progression of atherosclerosis, and other medications are given to reduce blood pressure and improve heart function. But medication isn't the only thing that can be done. Lifestyle measures are very important. Stopping smoking is critical, but all patients will be encouraged to follow a healthy diet and to undertake cardiac rehabilitation, a graded exercise program that will gradually improve physical function after a heart attack. So, having discussed a nice case of where the plumbing of the heart can be affected and can be treated, I'd like to spend the last few minutes discussing a similar scenario for the electrical system of the heart. The heart is dependent on electrical activation in order to beat, and you may be aware that the normal pacemaker activity comes from the sinoatrial node that sits at the top of the heart. Electrical conduction spreads through the atria and then through the atrioventricular node, or the main electrical junction box separating the atria from the ventricles. It then conducts down through specialized conduction tissue and leads to ventricular contraction, meaning that there is coordinated atrial contraction followed by ventricular contraction. The atrial contraction acts to maximize ventricular filling and maximize the amount of blood that can be ejected in each heartbeat. We can recognize these phases of the cardiac cycle on the surface ECG. This little bump is called a P wave and refers and is the manifestation of atrial electrical activity, whereas this larger complex spike is called a QRS complex and refers to ventricular activation. And we can see the coordinated activity on the surface ECG, a P wave followed by a QRS complex, P wave followed by a QRS complex, meaning that we've got coordinated atrial activation followed by ventricular activation. This complex is called a T wave and refers to the repolarization or reset of the ventricle. Abnormalities of the heart rhythm can be where the heart goes fast or slow. In slow heart rhythms, there can be problems with either the sinoatrial node or the AV node. In this example, we can see that this sinus node disease, P wave is followed by a QRS complex and a T wave, but then there's no P wave activity for several seconds. This is sinus node disease and may cause the patient symptoms such as dizziness or even a blackout. This example is different. You can see that there are P waves that carry on, and there are QRS complexes that carry on at a different rate, and there's no apparent relationship between the two. There are more P waves than there are QRS complexes, and this is what we call complete heart block, where the AV node has stopped working, and so the pacemaker activity at the top of the heart is not influencing the overall rate of ventricular conduction. This is a dangerous situation where the patient is at risk of having their heart stop, and the treatment for this is to implant a permanent pacemaker. These days, implant of a permanent pacemaker is a relatively straightforward procedure that can be done in less than an hour. Small floppy leads are maneuvered into the heart and connected to a small pacemaker generator that sits under the collarbone. This diagram illustrates how the pacing leads enter the vein that goes down to the heart, and often a pacemaker will have two leads, one sitting in the atrium and one down into the right ventricle. These days, treating a slow heart rhythm with a pacemaker is a very straightforward procedure, but of course this was not always the case. Before development of modern pacemakers, pacing involved huge, great big devices that were not portable, and so patients would have to be hospitalized for the entire period that they needed a pacemaker. This was the actor Peter Sellers, who needed a pacemaker in the context of a heart attack. This was the first implantable pacemaker that was invented in around the 1950s. And the first implant was into this patient called Arne Larsen by his cardiologist and the technician that developed the pacemaker. Arne Larsen actually did very well and went on to outlive both the cardiologist that implanted his pacemaker and the technician that invented it. This is him later in life. He was a Swedish man that was very keen on boats, and he actually died of cancer, completely unrelated to his heart problems, in his 80s. So to summarize, I've given you a brief introduction to cardiology, including some aspects of cardiac imaging, showing you how coronary artery disease can affect patients, and talking about heart rhythm problems. I hope this serves as a broader illustration that scientific understanding of normal function and disease processes is essential to developing modern and effective treatments. Of course, we still have much progress to make across many fields of medicine, and I hope that one or more of you may in time contribute to this. Thank you very much for your attention.